Talking to patients about urine drug testing is certainly emotionally charged. I think when pain experts tell us that we should be doing testing on our patients, they don't understand how difficult it is or where we come from in primary care. I know how I was trained. I suspect for many of you, you were trained in a similar manner, that we're supposed to be the advocate for the patient. That medical care is so confusing and complicated today. We are the captain of the ship that's guiding patients through the troubled waters of care, and it really is very complicated. So we are the advocate for the patient. We stand behind them. Whatever they say goes. We're trying to get them the medical care they need despite pre-authorizations and insurance issues and everything, so that when we confront the patient with something like urine drug testing, why we need to do it, or even a result that isn't what we expect, it becomes a big deal. And if you're not right, if it shows up that something you accuse the patient of really didn't happen, that happened to me recently, oh my God, it was a big deal. I got a complaint, it went to my record. So we become afraid to even do the testing because we don't know how to ask the patients and we don't know how to tell people about the results. So I'm going to ask my panel here of the method they use to ask patients to initiate this discussion about urine drug testing, and then if something shows up in the urine that's abnormal, how do you go about approaching patients with that result? So let's start first with, how do you ask patients to do the urine drug testing when it's something new and they have never been asked before?
I have it part of the treatment agreement, and before I write the first prescription, I go over the treatment agreement with the patient and whether they are comfortable with it, understand it, and agree to the treatment agreement. And part of the treatment agreement is doing urine drug testing, and I point out it's doing it for the patient, not to the patient. It's for their benefit. And I point out the ways that urine drug testing could benefit them as we sort applications for such and such. You know, that a urine drug test is appropriately positive, appropriately negative would be very, very helpful to them. But I have to base all our communication on mutual trust and honesty. And I point out very early in our relationship, I have a responsibility to the patient, and the patient has a responsibility to me, because we're dealing in an area that the public really doesn't understand. Even our colleagues don't understand the difference between addiction and physical dependence, which are entirely two different physiological events in the body. So I try to inform the patient why I'm doing the urine test and how they could benefit from the urine test, and I'm not doing it punitive because I do not trust them. Now again, what comes up first is if the patient says, well, I'm not an addict, doc, why am I doing that? And I say, you're not an addict, but that's the protocol for my practice, is to do urine drug testing, and I do it for everybody. I'm not picking and only doing it for the green person or the yellow person, etc. And then the next question is, we discussed, I don't think that I should do it. It's my right not to have the urine drug test. And then I explain to them, it certainly is your right not to do the urine drug test, but then it will limit the care that I could give you and prescribing certain class of medication. And the patient again gets to make the decision. So again, you have to be open and honest with the patient right from the onset and describe how your practice works before you write the first prescription.
So Michael, certainly in our practice, we start that opioid never thinking it's going to be continued. And 90% of the time, the acute back injury, the acute ankle sprain, the neck whiplash injury, they go away. So it would be impractical for us to have an opioid agreement on every single patient we start on an opioid. So I understand what you're saying, Howard, but in our setting, there becomes a time when the opioid agreement makes sense, and It doesn't on that first prescription typically. Sometimes it does, but typically it doesn't. So how do you explain doing urine drug testing if the patient's now on the opioid, they've been on it a while, and now you're going to initiate urine drug testing for whatever reason?
Well, I think that you can always define the starting point, and using the context that Howard mentioned, I think that you can sit down with the patient and say, for example, we thought that this was going to be a short-term treatment. It's turned out that it has now become a chronic treatment. if we're going to continue on this therapy, and we should think about whether it's really effective or not for you, there will be certain changes that have to occur as far as the monitoring of its effectiveness, its side effects, and perhaps unintended consequences. We know that this is a medicine that's at risk for developing addiction. We know that this is a medicine that people tend to misuse in particular ways. Some medicines people don't take enough of. This is a class of medicine that people tend to overuse. And so therefore, given the risks, given the interactions, given the many other drugs that could be problematic with this particular therapy, we need to do this kind of monitoring. And as we go along, I'll be discussing with you the results of that. And these are the potential outcomes. I might find a test result that doesn't make sense to me, in which case I'll have to sit down and talk to you about it. And I more than likely will want to talk to other people that have been involved in your care or who are part of your support system to understand the inconsistency. That's what I'm looking for.
And sort of like you wouldn't do a drug contract agreement on a patient at that first visit, that when you start the urine drug testing may be the same time you do an opioid agreement on the patient, because now it's clear that they're going to become chronic users because of their pain condition.
And I think they're binded together.
Yes, and I think what I would oftentimes say with the agreement is that I use it as a tool to facilitate the conversation, to educate the patient, and, you know, for a bit of efficiency's sake, to say, as we shift gears, there are a number of changes that are going to occur. And I want you to have something to refer to after the fact, because you may not remember how we're changing the paradigm right now.
Absolutely. Human, do you have a different way of...
Clearly there is a difference of how we handle this type of approach when it comes to talk about urine drug screening between a specialist and a primary care physician. And I know the challenge of primary care physician. You've been having a patient for 15 years. They said, we overdid it in snow shoveling, or we overworked at the garage. Now I have severe back pain. They give them Vicodin or Percocet or whatever medication of their choice. They don't feel the need to go through the whole opioid agreement and through the whole urine drug testing. The problem becomes when this becomes more of a chronic issue, becomes more of a monthly occurrence. And I agree with Michael, at one point you're going to have a start point. And I would not really call it a confrontation when I sit down and talk to my patient. When you have a patient who comes to you with 400 of glucose, you sit down and you discuss the result with the patient. Say, why it's 400? We have to alter the plan. The same exact thing when we're going to sit down and discuss the outcome and the results of the urine drug screen. And I can tell the patient, I said, patients, I'll give you another example of the start point where Michael pointed that out. If a patient becomes who has atrial fibrillation, you're going to start on Coumadin. The rules of the game changed. Now we have to monitor the Coumadin. Now we have to. There's a point where we're going to start something new, and this is where we're going to starting something new. We started opiate. Opiate comes with a certain package. It's urine drug screen. It's an opiate agreement, and I agree with Howard that. The point that you're going to start this, you initiate everything together. You initiate the urine drug screening, you initiate the opioid agreement to tell them that this is the beginning of a new era. So,
and when is that beginning? When does the panel feel that when do you cross the magic line from acute pain to a chronic pain patient?
You go by the definitions. If you go to the textbooks, the definitions anywhere go between 6 weeks to 3 months, where the acute become a chronic, or if an acute has surpassed its natural recovery, meaning if a patient have an appendectomy or a hernia repair, I expect them 1 week, 2 weeks at the most to be on pain medication. Then usually it heals and they go back to work. Let's say 4 weeks pass and they continue to have severe pain. It's no longer post-operative pain. It's no longer acute pain. Now it's becoming a chronic issue. So, I mean, this is where the judgment, again, the clinical judgment comes, and that's where you cross line. But definitely in major textbook, 3 months is the definition of chronic.
And I want to point out also, many times these patients come to us, we start some therapy, they go away to a specialist, they get therapy there, and they may come back to us a lot later than that. And now they're in their chronic pain and they're on the opioid, and you can't even remember why they came in. for the first place. So it's a little different in primary care, but just to give you an idea, Dr. Stephen Pasick did a study of primary care doctors to see when did it look like prescribing would become chronic. In other words, if you had a certain number of refills on your hydrocodone is what he looked at. When is it likely that is going to become a chronic pattern? He found after the third refill that it was much more likely it would go on for a year. So you should be thinking about your own practice. When you write that third refill, is it now becoming chronic, and do you need to initiate some opioid agreement, urine drug testing, the prescription monitoring program? I want to thank the panel very much for this interesting discussion.